All right, 5 minutes after 11 o'clock. Thank you for tuning in this Thursday morning. We're going to learn what we need to do to be healthy. And I've learned from these two gentlemen already. I'm not a good student, but I have learned a little bit. Dr. Ivan Levinrad is in the studio. He's a physical therapist with Strive Physical Therapy Centers. He specializes in lots of stuff, including orthopedics, spinal conditions, sports injuries, and even was kind enough to send me a guide so that I could work my way into healthierness. I've given up mayonnaise. Does that help? I've given up mayonnaise. Dr. Jonathan Sherrouse, did I say? Sherrouse, thank you, is in the studio. He's also a doctor of physical therapy. I think that's what we're focusing on today is physical therapy. You specialize in treating trauma patients, acute care and ICU patients, as well as orthopedics. And again, the phone lines are open during this discussion. So if you out there would like to call the doctors right now, the number is the WOCA Climate Control Source Hotline, 622-9622. Dr. Sherrouse and Dr. Levinrad, good morning, gentlemen.
Good morning.
How you both doing?
Very great.
I'm a little embarrassed. I'm not that good of a student. The first thing you asked me, doctor, was, have you been walking? So I told you I walked to the curb.
The truth hurts.
And at least you're honest with yourself. That's good. So.
But I did give up mayonnaise. I was bad with mayonnaise. Have you ever heard that before? Has anybody ever told you that they're bad with, like, you know?
Everybody is bad with mayonnaise.
Not me, not anymore.
Most people.
Not anymore. No,
I stand in the subway line and watch people when they order their sandwiches. They all say double, lots of mayo, double the mayonnaise.
Yes. Oh, we'll see. I used to get the jar, and it would be gone in a week, right?
Yes.
There's nobody in my house but me. I am not lying to you.
That's like eating lard.
Yeah, or Crisco, yeah.
But I don't do it anymore. I put it, you know how I did it? I told myself, look at it like a cigar. Because I gave up cigars, too, like 8 years ago maybe now. Mm-hmm. So it's one of those, you know how they say, do things in moderation? I can't. It's all or nothing for me.
Cold turkey.
Yeah. So when I start walking, I'll be walking around the world. Anyway, good morning, guys. When I hear the word physical therapy and then I hear the word occupational therapy, I'm always confused. I don't know what is what. Is one with the hands and one with the feet?
Well, no.
Not necessarily.
No. Occupational therapists are treating people with regard to active daily living activities. In other words, how to dress themselves, how to clean themselves, how to feed themselves. If you've got severe arthritis in your hands and you can't hold a knife or a fork, they can adapt equipment for that. But there is a little crossover with involving functional activities like sitting, standing, walking.
Especially in the hospital setting as well, too.
Exactly. Now, physical therapy is more involved in returning person to their prior level of function with regard to
gross movements,
broader aspect of activities.
So how do you do that? I mean, do you take them by the hand and walk, or how do you do it?
A lot of times.
Pretty much. I mean, someone is in bed. Let's take the acute care situation. They're in bed. They've been in bed a week, a couple of days, maybe months. And now we get them up out of the bed. For a person to sit over the side of the bed is a lot of effort.
Even that alone can be exercise in some circumstances. So
really?
Right.
Oh, yeah.
So can they sit over the side of the bed? And then can they stand? Then we've got to get them to a chair. Can they walk? So we've got to evaluate this and progress it and reassess them continually. Yeah. And accordingly, maybe they need a roller walk in the beginning. Maybe they need just a cane. But typically they need a roller walk with a lot of assistance. It depends, of course, how acute they are. Not cute.
I heard that. I was going to make a joke.
Yeah.
I was trying to read your face.
I see the look on your face.
Well, how do you keep the muscles from losing their function when they're in bed all those months?
Oh, yeah.
That's the challenge we deal with on a daily basis. Mm-hmm. There's studies out there that show that just one day of bed rest, basically multiply that by 3, and that's the length of time of good solid activity to get that strength and conditioning back.
Oh, really?
So you figure these patients that we have sometimes coming in here that have been, bed bound and in the hospital, or even before they get to the hospital, in a lot of cases they've been down for a month or so. It's like, well, you're looking at 3+ months of recovery time just to get back to your baseline level of function. So, and that's if you're diligent and willing to put the good work into it. So, but it's basically just getting back on track. You got to start somewhere, and even if it's something as simple as just a little bed exercises, even though I always say that's kind of the last priority in my opinion. But if you got to start with that, if that's all you have to work with, well, start with that, and then gradually progress to working on transfers. And what's true for some patients may not be true for others either, though, because some people weren't ambulatory and haven't been ambulatory for years. But we don't expect to come in there with a magic wand and just wave and say, okay, we're going to make you walk again. I mean, you got to be realistic with a lot of these things as well too. But just repetition is probably the big way to get that strength.
You guys must understand also in trauma, we can deal with a person that's in their teens and a person that can be 80, 90 years old. Absolutely. And we see a lot of that. It could be a motorbike or motor vehicle accident or a fall.
Right. And we have to tailor our approach to that.
So, of course, it can be so broad, the functional activity level that we start off with and what we want to ultimately gain. Of course, it depends on the extent of the trauma. You're working with a team. A team approach is very important.
Absolutely.
Not only the doctors, the orthopedics, the nursing staff, the nutritionists, occupational therapists, the speech therapists are very important.
Respiratory therapy,
respiratory therapy. Thank you. There's a lot of approaches here that is not just physical therapy or occupational or just the MD or just the orthopedic surgeon. The approach is very multifactorial.
When you mentioned the younger end of the spectrum and the older end, I had a thought there. How do you measure progress, and what are your expectations? If somebody's 89 years old, you might not have the same expectations you would for an 18-year-old, right?
The way I approach it, and I tell patients all the time, is like I go into the room and I say, listen, I have no preconceived notion about what you should or should not be able to do. And right away, you're already building that rapport. Is like, okay, so I don't have to get up and walk a marathon today. Of course not. I mean, but you got to start somewhere. And I said, as long as you're on a general trend to where you're gradually progressing each and every day, I'm happy. I don't care if it's at a very slight slope or a very steep slope. As long as you're going in the general right direction, I'm happy with the progress that we're getting. What we don't want to see is we don't want to see you start to plateau and be satisfied with something that's subpar. I mean, if you were completely independent beforehand, our goal is to get you back to being completely independent again.
Okay.
It may take you, a few days, it may take you a few weeks, months, or even years in some circumstances, depending on, again, the level of the trauma. But I think it's important not to have a cookie cutter approach to things and to tailor it to each individual, because even if they may have the same exact injuries as somebody else, they may have a totally different personality. They may adapt to, they may be more anxious. They may have more the problems adapting to different things. So you just gotta just kind of take what you're given, and again, as long as you're heading that right general trend, then you should have good progress.
You must hear a lot. They must talk to you when they do this.
Well, yes and no. It depends.
Oh, really?
You have some patients that are unable to talk. Yeah. They could be head injured. So again, it just depends on the trauma that they've sustained. Now, you might have a lady or gentleman that's elderly that were wheelchair bound before you saw them. Mm-hmm. So we're not going to get them to walk afterwards. So obviously, you try and get their prior level of function documented before you treat them. But it's not always possible either. Every circumstance, as Jono said over here, you got to tailor each individual rehabilitation procedure or process. Wow. And the process can be a long process. They come from the acute care, we can get them up sitting and standing and walking maybe a short distance. Then they're going to progress to a rehabilitation center. They can be there for months. Mm-hmm. Then they can go home and then continue physical therapy at home, rehabilitating themselves, and then they can end up in an outpatient physical therapy clinic and continue with rehab. So sometimes rehabilitation can take a lengthy process of years, including speech, occupational and physical therapy, medical care, nursing care. Somebody could be a quadriplegic, somebody can be have a stroke. It's a very broad spectrum of trauma and conditions.
And going back to your previous question too, you're talking about how much they talk with us and everything. Kind of going back to that point is that one thing that we have heard, or at least I have, and I'm sure Ivan has too, on a pretty consistent basis, is that we do probably spend more time with our patients than pretty much any other discipline in the hospital, I guess, because nursing staff, I mean, they have 12-hour shifts, but they're servicing probably 6 of the patients in that 12-hour shifts. In our ICUs, they're typically on like a 1-to-2 ratio in most cases. But they're in the room, they're doing things with the lines and stuff, and then they're out of the room. And, the doctors, they do their rounds once, sometimes twice a day, for a few minutes, and then they're gone. The respiratory therapists in there for a few minutes and they're gone. We spend half an hour, 45 minutes, sometimes an hour or more with our patients in a given day, and that's just one session of therapy. Sometimes we're getting 2 sessions a day.
Oh, really?
Or we're getting PT and OT, sometimes 2 or 3 sessions a day. So we are spending quite a bit of time with our patients. So and you do
that's 7
develop
days
those
a week.
relationships. Yeah,
That's 7 days a week.
Do
we
you
don't
do
take
it-
off weekends. We work 7 days a week.
And,
so.
and it sounded like you do it in their homes or maybe in the nursing homes or.
We're typically working only in the
Yeah.
hospital setting.
okay.
But there are physical therapists that specialize in home health care, outpatient physical therapy, rehabilitation physical therapy, and occupational therapy and speech therapy. I always want to include those because, again, the whole rehab spectrum is not just physical therapy. Occupational therapy, speech therapy is very important with the nursing care, with the MDs.
Right.
And what's fantastic is where we're at Ocala Regional and West Marion Community Hospital, but Ocala Regional is the trauma hospital, is that the care, the teamwork with the doctors and the nurses and all the disciplines is fantastic.
Wow.
I've had the pleasure of working at many other hospitals over the years as a therapist, and I want to tell you these guys are fantastic.
I don't think I've ever had, and I'm not just trying to toot their horn, but I don't think I've ever had a group of doctors that have been more readily accessible. Every morning I come in here and I see my list, and there's 2 numbers I can call. I can call the doctors and the PAs that are in the ICU, and the doctors and the PAs that are on the floor. I give them a call. They answer phone. I ask them all my questions. They answer all my questions for me. You see them in the hall all the time. We see them in the ICU. You just walk up to them. I mean, they're very readily accessible, which is so key to having good patient care is good communications amongst all the healthcare professionals.
Correct.
So do you start physical therapy in ICU?
Oh, absolutely.
You do?
A
Absolutely.
big misconception. I'm very happy that you asked that question. Big misconception that a lot of people have, and if you go back even just 10 or 20 years, okay, the amount of progress that we've made, I think, in this department has been so great that the old notion used to be, well, if you have a big traumatic injury, let's say you have 3 broken limbs out of the 4, and you
Right.
have all these internal organ damage and TBI and all these types of things.
Is that TBI?
A traumatic brain injury. Sorry.
Thank you, Robin. I was pretending.
It's not long there. So,
TBI.
but yeah.
impressive.
So even yeah.
Ask.
And so no, please do. So even with all these things, the old notion used to be is that well, they need to be on bed rest. We need to keep them in bed. We need to let them rest. And those types of things. That's probably the worst thing we can do. We get the physical therapy order for all these patients pretty much the moment they walk through the door.
Wow.
Yes.
Of course, we wait till they're medically stable, but typically, in most cases, post-op day 1, and in most cases, we're working with these patients. It may be only range of motion in some cases, but in a lot of cases, even if they're still on the ventilator, we sit them up on the edge of the bed sometimes. I've even walked patients
That's
that are
right.
still
See,
on the
that would be
ventilator
me.
before.
I
watch.
So-
I would want right away. I mean, okay, I'm done with this. That happened yesterday. I'm ready
Yeah.
to walk again.
And if you ask most patients that same question, of course, if they have all their facilities with them, then or faculties with them, most of them will say that yes, they want to move. They don't want to be glued to the bed. They
Right.
get stiff. They get sore. They start getting bed sores and other complications. So
But it's challenging, guys.
It's very challenging.
We've got patients that have got bilateral femur fractures. That's a big thigh bone fractured.
Amputations.
Arm fracture,
wow.
amputations. And you sit them up over the side of the bed a day after surgery. It's not very
Did you get that guy that was hit by
very
the train
painful.
a couple days ago? He lost both of his legs. Did he come to your hospital? Yeah.
We don't talk about specific.
Oh, I'm
we can't
sorry.
comment
I'm
on
sorry.
We're not allowed to do that.
Well, I don't know his name.
I've got.
we have
Be politically
we have HIPAA
correct.
laws
We have
and all
a,
that kind of stuff.
HIPAA
We can't
laws.
really
We don't
say,
go
so.
there.
if you put your headphones on, you'll be able to hear the phone call. We have a phone call coming in, so let's take that call. While they're putting the headphones on, again, Dr. Jonathan Sherrouse and Dr. Ivan Levinrad are in the studio. Good morning. Thank you for calling. You're on the air with the doctors.
Hi, Larry. This is June. I missed the beginning of this, so I don't know if this will apply to the question I have. I don't know if you're just talking about trauma, but I'm wondering if they know anything about shoulder replacement therapy, shoulder replacement surgery that I have been recommended for, and I've talked to a couple surgeons. I'm just wondering what their opinion is of it and what the recovery rate is and how good is it. And I will hang up and listen if they could answer that. And thank you, and God bless you guys.
Okay.
So I'm going to defer to
Very
Dr.
good.
Ivan for
It's a
that one
good-
because
it's a
he
good question, no problem.
has a little more experience with this than I do. So
It sounds like the patient is obviously deciding to have it or not have the surgery. All I can say is that if you're in terrible pain and you're lacking your function, one of the big factors in having a total shoulder replacement or shoulder surgery is function and pain. Probably I'll say pain before function. So if you've got a severe arthritic shoulder joint that you cannot functionally use it at all, but you're in a lot of pain, I highly recommend a shoulder replacement. And the most common one done today is a reverse total shoulder. I'm not going to go get into that in too much detail, but basically they replace the anatomy of the ball of the top arm bone, the humerus, and the socket on the scapula, and they actually reverse the anatomy of both joints, and it works fantastic, and they're pain-free. However, they will get more function, but they'll never have the function that they would love it, put their arm over their head and so on and so forth. But having said that, I've seen some people that have gained much more function, but at least they're pain-free. Now, if she's talking about general shoulder surgery, rotator cuff surgery, I highly recommend that you get at least 2 or 3 opinions. Make sure that the diagnosis is correct before you have rotator cuff surgery, because very often good physical therapy can prevent the surgery. However, if you've got a severe trauma and tears and disruption of the rotator cuff, a lot of people say rotator cuff. Layman is wrong. It's rotator cuff, C-U-F-F. It's a cuff of 4 tendons that envelop the head of the humerus, the top arm bone, that allows rotation and movements above your arm and to the side. And if those are disrupted severely, then you need some surgical repair. But again, after any shoulder surgery, you need significant rehabilitation, both occupational therapy and physical therapy. Very, very important. So don't go into the surgery lightly thinking, oh, the doctor's going to replace the joint and do the surgery, whatever it is, and then I'm just going to wave my arm around. It's got a
very
lot
easy,
of
very quick for that to
rehabilitation.
freeze up on you if you don't get a good range of motion mobility afterwards. So.
Also, if you look at the shoulder joint, look at what you can do with the shoulder joint, the multi-axial movements. You can rotate, circumduct, put your hand behind your head, behind your back. Try that with your hip joint or your knee joint. It's not going to do that. So the multi-directional movement that the
I knew a
shoulder
woman,
joint
though.
affords, it's important for rehab. I know you've tried that.
I know a
Didn't
woman
work
who could
so
do
well.
that. I knew a lady. I knew a lady who could do that. Yeah.
I know.
So you said something pretty interesting in there. You said that maybe physical therapy could enable her to avoid surgery.
Yes.
That almost sounds like something a chiropractor might say. Is it similar to what?
No. Chiropractors deal with the spine, and I don't want to get into chiropractics.
Okay, but a lot of times they'll say physical hands-on, which is what you sounds like.
Which is why we call it physical therapy.
Right.
Physical therapy is physical therapy. And we specialize in musculoskeletal injuries and strengthening. And it's really important that you do strengthening prior to any surgery to the shoulder joint, unless you've got severe degenerative joint disease, arthritis, in other words, osteoarthritis, and you're going to have it replaced.
So most good doctors are going to tell you that, tolerate the pain until you can't tolerate it anymore, because once you have surgery, there's no going back. Once that decision is made. So I always encourage patients, like, look, if you're on the fence like this, if you haven't seen a physical therapist, of course we're biased, we're both physical therapists, but this should just be common sense for most people. Start off with more conservative treatments first before you go and do something very dramatic, such as a surgery where they're taking off portions of your bone and everything else too. In a lot of cases that very well may be necessary, but what do you have to lose by going to a physical therapy or something like that and seeing if that works? Your insurance probably will cover it, and you're only out maybe a couple $100, if that, versus going to a doctor and being pushed into doing something that you're kind of on the fence with, and then you could get by it for possibly several more years. Other thing too you got to consider, it's not as common with this shoulder, but with other joint replacements such as the hip and the knee, is that there's a life expectancy on that joint replacement. It may wear out eventually. You may have to get it replaced again.
Oh, really?
So
how long?
It depends for every individual. It depends on how active you are.
Oh, wow.
And so the shoulder is not quite as common, but with hips and knees is very common.
The knee joint, when I started physical therapy in the 1980s, they said that a knee joint lasts maximum 10 years. Now they're lasting 20 years. They've improved the materials.
Oh.
But it depends on the person's activity level, as Jonathan said. It depends on their weight. That's very important. There's a lot of variables, how you rehabilitate it and so on and so forth. So you don't want to go and have it too soon. But as Jonathan said, and I want to reinforce this, what's the worst? You do a few weeks of strengthening. If you still have the surgery, your post-op strengthening level that you're starting with is going to already be ahead of the game.
So you still come out with something.
And
so.
on the other hand, maybe you do better. My sister called me up a year ago. She hurt her shoulder. She went to go see an orthopedic surgeon. He recommended doing some physical therapy, or he could do surgery. She asked me my advice. Obviously, I said, go and do the exercise. I gave her exercises. Guess what? A year and a half later, her shoulder's 100%.
Oh, that's great.
And that we hear more often
Good
than
brother.
not.
You're a good brother. We have another phone call, so if you'll put the headphones back on. Thank you for calling. Good morning. You're on the air with the doctors.
Hi, Larry. This is June again. I hate to occupy your whole show, but just to inform everyone there, the doctors and the PTs, that I have done physical therapy and every other type of electrical, muscular stimulation, magnetic therapy. I've done everything I could. It is bone on bone, and they say there is no other option. So that's why I asked your opinion about it. And I'm wondering, I don't know if you can do this or not, do you have a surgeon that you could recommend that I could talk to over there? And I'll hang up again, and thank you guys again for listening to me.
Okay, thank you. Yeah, it sounds like she's done
everything as we said, and she needs a surgeon.
She did it the right way.
I don't want to go and recommend a specific surgeon. There's a lot of good surgeons in town that specialize in the shoulder.
Shop around.
What I would recommend is, that's right, I would go talk to friends, and I would also go on the internet and look up the shoulder doctors in the Ocala area.
And Suzanne is writing something.
And you can find a lot of information on the internet, and I can guarantee you that we've got a lot of good doctors here. I'm not going to go and mention any one specific doctor.
Right.
That wouldn't be fair. But I can tell you we've got a lot of good doctors in this area that will do that procedure. But I highly recommend she go ahead and she does it.
And thank you. Suzanne gave me the phone number for the physician's referral.
Fantastic.
It's 1-800-530-1188. Are those eights? Okay. 1-800-530-1188. So the idea that you could perhaps avoid something serious with the physical therapy.
Sure, it's always worth it. It's always worth it. In fact, the evidence shows, for example, the total knee replacement, that if you do physical therapy, you can push it out for a good number of years before you come to a total knee replacement very successfully. But there's going to come a time where the joint wears out eventually, and you'll know when you need to have it done, when you're so painful. And the doctors won't just go and do a joint replacement.
They have stipulations.
Yeah, that's exactly right.
Incapacitating just about.
Sure. And they're going to make sure they do it when it's necessary. But at least you can have more function for a longer period of time with less pain by keeping the joints around, the muscles around the joint, stronger.
I'm going to ask you something that might be pushing the envelope a little bit, but we know a guy who had knee issues. I don't want to say they were replaced. I don't know what they did, but they used what do you call stem cell therapy, and he's swearing by it. What are your thoughts on that?
That's a tough question, because there's such new evidence in it, and it's such a new field. And I'll be honest, I haven't had much contact with those patients.
Okay.
I've had one other patient that has also had that procedure done, and they also had very positive things to say about it. That's the only other person that I know firsthand that has actually had it done. So it is pretty new. Appears to be looking pretty good in most cases, but it's also one of those things where time might tell. It's like, yes, things might be good now, but you look at a lot of this research, well, wait till you're about 3 or 4, even 10, 12 years down the road,
then we'll know
and then see, so it's going to be a little while before we have anything concrete on it. So.
Medicine is going ahead, and I guarantee they're going to use stem cells in the future, and who knows.
You guys are great, and it's so nice to have you back. I think sometimes when people have been here once before, it's more comfortable the second time. Do you feel that way?
Sure.
I'm just as comfortable.
You're just as comfortable?
I felt pretty good the first time, too.
Yeah, but the last time I think we occupied your time with your accent.
You're very inviting.
All right, before we only have a few seconds left. The physician's referral, 1-800-530-1188. We'll hold on to that. Any other numbers we want to give out?
Oh, that's good.
Suzanne,
I just want to say that, our trauma program, these folks have been working with, we've treated over 3,000 patients, trauma patients, since we started.
Has it been that many?
Wow.
It has been, yeah.
That's 18 months now?
It's since December 8th, 2012. Yeah.
Wow.
So.
That's fantastic.
And nearly, it is, and nearly 1,000 so far year to date. through 2014. So yeah,
Wow.
there's a lot of patients these guys are helping. A lot of
we're busy.
families too.
That's awesome.
That's
A lot of
right.
families. Yeah.
And I'm guessing there's a little bit of psychology.
Oh, not a bit.
yeah,
A lot.
a lot
of it.
lot.
Yeah.
Probably the biggest part of our job is getting the patient to work with you, getting the family to work with you, and the patient is not just the
Motivation,
patient, the
and
family
where
is
the patient's head's
important.
at. I can't agree with Ivan more. That's
Attitude.
half the battle, at least.
I tell all my patients, attitude is 90% of your success. If you're positive and you want to get better, guess what? You'll get better.
I will. See, that's me. That's me.
right. That's right.
Nobody needs to coach me to be a positive person. I'm always a positive person. Dr. Ivan Levinrad, good to see you. Dr. Jonathan Sherrouse, good to see you. Leah Caruso, you didn't say much today, but thank you for coming in. Good, and thank you for bringing these wonderful guests. And Suzanne Santangelo, good to
Yes.
see you. Thank you so much.
Thank you.
Any other phone numbers you want to give out?
No, that 800 number is the key.
That is a good one. Yeah,
Yes.
that is a really good one.
So.
Thank you. Thank you, doctors, and thank you, ladies. All right, we will take a little break, and we'll be right back.
Habitat for Humanity of Marion County is a ministry dedicated to improving lives by providing affordable and decent housing. Help them help others by visiting the Habitat for Humanity Ocala Restore at 926 Northwest